Excuse me, ladies and gentlemen, we now have our presenters in conference. Participation in this presentation is by express written invitation of the AHA only. Unauthorized participants and/or any party that aids and abets such unauthorized participants may be subject to criminal and civil penalties under both state and federal law. Please disconnect from the call or log off the webinar if the AHA did not expressly invite your participation. It is now my pleasure to turn today's call over to Abby Avinsky. Please go ahead.
Thank you so much, Brandon. Hi, everyone. Good morning or good afternoon, depending on where you are in the country or even the world. My name is Abby Avinsky, and thank you for joining us for the November 2018 AHA Team Training Monthly Webinar. We have a great webinar lined up for you guys today. A couple rules of engagement before we begin. You can listen to the audio in two different ways. You can dial in through the phone, in which case you'll want to mute your computer speakers, or you can listen through your computer speakers. To mute your computer speakers, there's a button at the top of the meeting bar. If it is green, you will just want to click it and hit Mute My Speakers. We will do a Q&A at the end of the presentation, but please chat in questions as we go along in the chat box. We will try to answer any logistical questions right away, and we'll hold more of the content-based questions until the end, and I will bring them up to the speakers then. A few short announcements. We are headed to San Antonio, Texas for our 2019 annual conference. We hope to see you all there. It's truly a great event. Our call for proposals has been released, so we would encourage you all to consider presenting your proposal for this year's conference. And just to remind everyone, the links are live, so feel free to click on any of the links in the presentation. We have one more master training course this year at Tulane University in New Orleans, and our next webinar will be on December 12th. This webinar is called Taking Steps to Sustain a Just Culture. Registration is open now. As always, you can reach us at the email and phone number on your screen, or check out our website at aha.org/teamtraining. And without further ado, I would like to introduce our speakers, Rick Lang and Tom Kuriakos.
Thanks, Abby. Good afternoon. My name is Rick Lang. I'm a fourth-year medical student at Robert Wood Johnson Medical School in New Jersey, applying currently to orthopedics. I completed the TeamSTEPPS Master Trainer course a few years ago. My personal background was that I was a Navy F-18 pilot prior to medical school. I served for 12 years in the community of naval aviation and its associated culture of safety and high reliability. I'm also humbled and honored to represent the 2015 class of Tillman Scholars from the Pat Tillman Foundation.
Thanks, Rick. Hi, everyone. My name is Tom Kuriakos. I'm also a fourth-year medical student at Rutgers Robert Wood Johnson Medical School here in New Jersey. I'm applying to pediatrics this year. I completed the TeamSTEPPS Master Trainer course alongside Rick and a few of our peers in 2016. By way of my background, prior to medical school, I was an educator in an underserved region of the Deep South, where I worked as a high school teacher and coach in Meridian, Mississippi for 3 years. It's an experience that's driven my interest in the work that we're going to talk to you about today. While we are the ones who are giving the webinar today, we do want to drive home that today's presentation represents a team effort by multiple individuals, both on the student side and the faculty side here at RWJMS.
Yeah, some other students on the team that have been instrumental in designing and implementing our initiative is Kevin Fitzpatrick. He is, all of them are TeamSTEPPS Master Trainers, but Kevin was a former Army Special Forces combat medic. Kristen Raffel, who is a former EMT field supervisor, and then Stephanie Latham is actually a couple of classes behind us at Robert Wood Johnson Medical School, also a former Navy F-18 pilot, and key to kind of sustainability from the student side with this initiative moving forward at our current school. All of us come from non-traditional backgrounds with kind of a shared passion for effective teamwork that's been gained from our prior professions before medical school. We also owe a huge thanks to our core faculty champions. For our core advisors, two of them, Dr. Carol Terragino, is the Senior Associate Dean for Education and Academic Affairs at Robert Wood Johnson. Dr. Gregory Peck is a trauma surgeon and Director of Trauma Performance Improvement at Robert Wood Johnson University Hospital, and then additional faculty champions that we kind of gained along the way within the curriculum. We owe a huge thanks to the AHA team support, or the TeamSTEPPS team over the last few years, specifically Abby Avinsky, who helped us get plugged into key personnel within the TeamSTEPPS community. A couple of brief financial disclosures. The American Hospital Association kind of partially funded the AMA home visit program, which is one of the survey groups that we had kind of integrated TeamSTEPPS into. And then the Pat Tillman Foundation funded, for myself, some travel and some scholarship support, some travel funding to the TeamSTEPPS National Conference in 2018. Also, being that I was a former military, the views in this and the work that we did are of my personal views, and they are not the views of the government or the U.S. military.
All right, so on this slide, you can find our agenda for today. As you read through, we want to kind of establish our goals for this webinar. They are twofold. First, we want to explain our project to walk you through the intervention that we put in place here at RWJMS and the results that we found along the way. Second, we want to discuss the lessons that we learned along the way and how we plan to apply them going forward. In doing so, we hope that we'll be able to spark some thought among our audience about how you might advance programs existing at your home sites. A quick note for all listeners, if you look at the file section on your Adobe platform, there should be two downloads that are available. The first is today's presentation, the slides, and the second is our Teamwork Playbook, which is one of the foundations of our intervention here.
So I discussed previously my background in the culture of safety within naval aviation, and I left active duty, and I started medical school actually 2 weeks after active duty. And so I assumed that although the professions were markedly different, that of medicine or medical school and that of naval aviation, that they were both risk-based professions with high consequences for human error, and thus would likely share the same core risk management strategies that have shown to decrease preventable error in risk-based professions. In starting medical school, what I found that I was a little bit taken back at how different medical student teams were. Specifically, they weren't briefing, they weren't debriefing. There was generally a lack of clear leadership within teams, and they didn't assign roles and responsibilities. So I wrote this clinical reflection after one of my first student team environments, and this is the fall of 2015, the fall of my first year in medical school. I was just, like I mentioned, kind of taken back at how unsynchronized the team was and how unsynchronized we were with actually the patient, and whether we were actually, combining efforts under a synchronized or a unified objective for the patient, and I think there was some question in all of our minds. So I tracked down Kevin Fitzpatrick, who I'd mentioned before as a former in my class, but also came from a former Army Special Forces combat medic background. And we both agreed that from both of our backgrounds in the military that there might be an underlying systemic training deficiency in how students were taught to work in teams at medical school and how they were taught to mitigate risk within the human system that is medicine. And so we found two interesting faculty champions that we mentioned earlier, and then we set out to investigate the challenges that we faced. We did an extensive research phase. It spanned like a year and a half. We started with high reliability organizations, and then as we kind of worked through our research, we pinpointed, or we kind of settled on teamwork as both a critical core component of high reliability organizations, and also what we felt was different between the military teams that we had experienced as well as medical student teams. And so, gaining support of the two other students, Kristen and Tom, we all completed the online version of the former AHRQ, or Agency for Healthcare Research and Quality, TeamSTEPPS Master Trainer course. One finding that we had within the literature that we used as kind of the backbone of our course and in developing our intervention was this, because this VA study, they have one linking teamwork training to reductions in patient mortality, and they actually have a very similar one from the VA linking teamwork training to patient morbidity, and they have very similar outcomes. So this specifically tied teamwork training to an 18% decrease in patient mortality, and it was statistically significant. And even more so, it showed that there's a dose-response relationship. For every increase in briefing and debriefing that teams were doing, then the mortality was reduced. And so this became a core component of our intervention and helped us to link what we were trying to do in medical school directly to patient safety.
All right, so as Rick just outlined, our research base gave us pretty clear evidence in support of teamwork and teamwork training in healthcare settings. So for us, our next step was identifying what that might look like in our specific setting, that is medical education at Rutgers. On this slide, you can see an overview of the RWJMS curriculum, which we feel is one that's pretty representative of curricula at other health profession schools, and specifically medical schools. As you can see, in general, years 1 and 2 are primarily didactic, and years 3 and 4 tend to be more clinical, where students are on rotations, having patient encounters at hospital sites or other off-sites. In addition, for our curriculum specifically, we have a longitudinal patient-centered medicine thread during which students engage with faculty, preceptors, and mentors in discussions about professionalism, ethics, best practices, and also engage in periodic inter- and intra-professional exercises. In looking at our curriculum here at RWJMS, our key finding in this phase was that the Robert Wood Johnson curriculum attempted to train teamwork behaviors solely through group exposure to team-based events and individual exposure through online modules intended to simulate teamwork. More specifically, RWJMS did not have an integrated teamwork training curriculum prior to the TeamSTEPPS intervention that we designed and implemented. So that being said, let's walk through what our initial TeamSTEPPS intervention was and what it looked like. Given the lay of the land that we had identified, we set a few goals for our intervention. The first goal was to understand teamwork behaviors within the existing quote-unquote exposure-based curriculum. And we set that goal because we wanted to understand the behavioral outcomes of an exposure-based curriculum. That is, a curriculum that intended to teach teamwork by putting students in team settings and assuming that they would learn teamwork that way. Goal number 2 was to increase teamwork behaviors. And we set that goal because we wanted to develop a foundation of teamwork within the medical student body, knowing that these behaviors would correlate with increased patient safety. Goal number 3 was to understand barriers to effective teamwork training in the existing curriculum. And we set that goal because we wanted to understand why well-intentioned teamwork interventions in the literature that we had reviewed to that point had showed varying results. In addition, we wanted to know how we could potentially identify areas for improvement with the goal of finding a sustainable and successful teamwork training program for medical and interprofessional education. As an additional long-range goal that we've outlined as our quote-unquote Hail Mary here, what we wanted to do as students within medical school trying to drive a new initiative was to drive that initiative supported by faculty in a way that could spark a wider cultural change within our academic healthcare system. The implementation focus that we set up on initially was to target the preclinical curriculum, that is years 1 and 2, with plans to expand into the clinical curriculum in later stages. And our initial student-faculty implementation team were our 2 student veterans, Rick and Kevin, and our 2 core faculty champions. Our next step was to identify the intervention settings that we want to implement our intervention in. Having seen teamwork interventions across the literature having varied results, we designed our study sample to include multiple settings so that we could examine the impact of our intervention across all of them. To start, we identified 3 team settings that already existed. They are, as you see here, the first-year anatomy lab, the second-year interprofessional home visit program, and the Promise Clinic, which incorporates students from all class years with some interprofessional collaboration. We chose these settings in particular because we wanted to potentiate the teamwork taking place in each of them, right, in the settings that the medical school had already set up, but also because collectively they targeted multiple student teamwork domains in a variety of inter- and intraprofessional contexts. On this slide, you can see an overview of our project timeline. As you can see, it starts in 2015 with the clinical reflection that Rick mentioned from way back in our first semester of medical school, and it spans through the current year, 2018. One thing that we want to emphasize here is that there was a significant period of research and planning that took place from fall 2015 to spring 2017, during which we worked to plan our intervention, brainstorm the potential hurdles that we might come across and solutions to them, and to build the buy-in that would eventually allow our project to be successful. Following that period, we started our intervention in earnest in July 2017. I'll hand it over to Rick, who will walk you through that intervention.
So we'll begin on the timeline here in July of 2017, where we did an initial student survey, an IRB-approved survey, to understand student behaviors in the existing curriculum, which was prior to TeamSTEPPS intervention, and in that exposure-based curriculum that Tom described. The survey we did was a 43-item TeamSTEPPS-based survey, specifically looking at teamwork behaviors of medical students, frequency of briefing and debriefing, and then student perception of curriculum, of teamwork training curriculum effectiveness. We used TeamSTEPPS surveys, specifically the TeamSTEPPS perceptions and the TeamSTEPPS attitudes questionnaire, but we do have to mention a couple of limitations as they're definitely pertinent. First of all, the TeamSTEPPS perceptions and attitude questionnaire, we combine competency domains in order to make one survey so that students would only have to take one survey before and after training. We also had to slightly modify the question stems in order to ensure applicability to medical student curriculum environments, such as the anatomy lab, where there isn't exactly a patient encounter or a patient that can talk to you as like some type of provider. We use the information from our initial survey assessment in order to develop a tailored student intervention, and this became the first of a series of iterations that we used to develop our curriculum. We're going to begin by talking about some results from our pre-intervention survey, and this is again that survey of students in an exposure-based curriculum. What we have here is frequency of briefing on the left across all three team settings. On the right, we have frequency of debriefing across all three team settings. You can see the question stem just underneath that. So on the left, my team meets to discuss the team's plan before team events, and then after team events is on the right side. On the vertical axis, we have from always to never are the student responses, and then the numbers of students replying are in the horizontal axis. So what you can see by looking at both of these graphs is that 60% of 283 students surveyed across the entire Robert Wood Johnson Medical School student body reported never or sometimes for briefing and debriefing. And actually only 10% of those 283 students reported always for briefing and debriefing. We also polled the students with some open response comments. And in order to look at just we looked at the quantitative data that we just saw, and then some qualitative data here. So students said they don't like working in teams because they don't understand the fundamental importance of it or the fundamental importance of teamwork. They said that limited tools are provided to teach students how to be effective team members of healthcare teams, and that evidence-based methods are not taught. They said there needs to be training to teach us how to do dissections in the anatomy lab, for example, as a team. And another student said school tends to tell us we are going to be leaders one day instead of showing us how to properly lead. Multiple students across the variety of the environments that we surveyed had comments about leadership, saying things like, I don't understand why there's all these leadership questions because our team didn't actually have a team leader. And that was something we found that was common across multiple domains. What we did from both a quantitative and qualitative analysis on our initial survey, right, is that it drove us to focus our TeamSTEPPS implementation design. We wanted to focus on first why teamwork is important, linking it directly to the mortality benefit that we previously discussed in the VA study. We also decided to focus the tools on how to execute teamwork and provide them more of an actionable item or a how-to mentality rather than just a bunch of theory and concept and didactic lecture. We also wanted to focus on team setup and structure and leading teams with a focus on briefing and debriefing, as those were clear competency domains that the syllabus looked like it was currently weak or on the weaker side of from our initial survey.
All right, so I'm going to talk a little bit about how we use the results that Rick just spoke about to actually design and develop the tailored student-faculty training that we implemented beginning in the fall of 2017. So in its first iteration, our teamwork training intervention consisted of 90-minute didactic presentations, tailored for applicability to each team setting. Each of these sessions was instructed by our student champions, all of whom were TeamSTEPPS master trained, and they were given to fellow students. So it was a peer-to-peer style of instruction from master trainers to the student body. In addition, we developed the RWJ Teamwork Playbook, one of the downloads that's available to you, which is a one-page reference guide of selected TeamSTEPPS tools, and Rick will describe it further in a minute. Finally, based on the results from our initial survey, we designed our intervention to target the specific competencies that Rick spoke to. First, teamwork and its relationship to patient safety, team structure, leading teams, specifically targeting the frequency of briefing and debriefing, and effective team communication. Using this model for our intervention, over the course of the 2017-2018 academic year, we managed to train 650 students through the sessions that were conducted by our student champion TeamSTEPPS master trainers. And with the interest that was generated among our faculty champions through this process, we were able to extend an invitation to Dr. Crane and Rita from Tulane to conduct an on-site TeamSTEPPS master trainer course at our home hospital, Robert Wood Johnson University Hospital in New Brunswick, through which 80 clinical faculty were trained in addition. At this point, I'm going to hand it over to Rick to walk through the RWJ Teamwork Playbook and kind of give you an overview of how that played its part in our intervention.
So as Tom mentioned, one of the things that we organized was the Robert Wood Johnson Teamwork Playbook, and this stemmed from the idea that we wanted to provide students, or students asked for something that they could learn how to do teamwork as a team. So we basically built this as a consolidated element of TeamSTEPPS-based tools, and we kind of like organized them into a single sheet white coat pocket playbook, allowing them to kind of leave the training that we provided and hopefully execute teamwork on the spot. The lecture that we developed followed the flow of the playbook after first solidifying an understanding of why teamwork was important in medicine. The point here was that there was no memorization, and what we stressed with students, because students don't like memorizing a lot of information with the swath of information that is given to them in medical school. So we said no memorization of any of this is required, and the goal is to just learn how to use the playbook during the lecture. It's divided into 2 pages, and what we're looking at is the front page. Page 1 was focused on team structure and leadership. What we told students is that you're going to use these tools basically nearly every time, or the goal is to use them every time you execute teamwork, and it was organized in a sequential flow from left to right. So above the black line, we have TeamSTEPPS pre-event tools, meaning a student would look at this and say, first, I have to do team setup checklist. And we slightly modified the team setup checklist in order to make it usable and consolidated to just what the points that we felt students needed to emphasize. Then they would look and see team events, brief, huddle, debrief, as a reminder of the flow of events, and then they would have a brief checklist. We actually, for the brief and debrief checklist, started out on our initial revision of this with the full TeamSTEPPS brief checklist, but we found that students weren't doing it because it was fairly long. And so what we did is we took some of the lessons that I had from aviation and we've heard from the aviation industry, and we made a core brief item checklist, which is shown in green, meaning these are the 3 or 4 things that you should brief every single time: goals, roles, responsibilities, plan, and a contingency plan. And then there's some optional items, meaning if you are the designated leader and you would like to go a little bit further in depth, then those are some of optional things that may be applicable to that brief that day. The same thing's true with the debrief checklist, because below the black line, these are the TeamSTEPPS post-event tools for leadership. It starts with the debrief checklist, again, core briefing items in green, optional up below that, and then some guidance on feedback and some barriers that students could look for during the debrief to see which ones apply to their specific event. Page 2 of the Teamwork Playbook were communication, mutual support, and situation monitoring tools that we found most applicable to the student environments. Not a linear flow here. This is simply more like an optional, or page 2 is like an optional toolbox, and students could kind of pick it based upon the clinical setting or what was applicable to whatever environment they were operating that day. Of note, for the Rev 3, and this is our 3rd revision of the playbook, we actually substituted the IPASS format and some Joint Commission handoff guidance on the right side of page 2 for the traditional TeamSTEPPS IPASS the baton, because students, again, feedback from them said that the IPASS the baton seemed to be too long. So given that the New England Journal of Medicine, there was an article tying IPASS, there was a combination of the IPASS format with TeamSTEPPS training to nearly a 30% reduction in preventable error rates, and it was directly literature supported. That was one of the reasons we decided to use IPASS on the right side of page 2 of our playbook. All right, so with this understanding, we're going to shift to discussion of results from our analysis. Here we are in our timeline. We did a 90-day post-training survey assessment using the same survey that we had previously described. This was basically looking at the difference between our pre and post groups. or pre and post training. We did a quantitative analysis looking at teamwork behaviors, and we looked at pre and post mean scores by teamwork competency. We then did a Cohen's d effect size because we didn't just want to understand statistical significance, we actually wanted to understand the magnitude of behavioral change within the student body and the groups that we chose to survey. We then looked at a qualitative analysis to understand the perceived effectiveness of the teamwork training curriculum at Robert Wood Johnson Medical School, and we looked at frequently expressed implementation barriers in order to determine what barriers were limiting training within the interprofessional or medical school environments as Tom described earlier. We then graphically plotted our results for a simple visual analysis. What we have here is our briefing and debriefing results from our post-intervention group. So you can see again on the left frequency of briefing across all 3 team settings. On the right we have frequency of debriefing across all 3 team settings. The STEM is the same. My team meets to discuss the team's plans before events on the left and after team events on the right. On the top, on the left side, we have from always to never as student responses, and then again on the horizontal axis, we have number of students that replied. You can see here in our post-intervention group, 60% of students reported always or most of the time for briefing and debriefing, and 12% of students, only 12, reported never for briefing and debriefing. And what we do is on the next slide, we'll flip back to our pre-intervention results so that you can compare the difference between what you see now and what we had during our exposure-based curriculum. Here you can see 60% in this case reported never or sometimes for briefing and debriefing, and only 10% had reported always. And again, we'll go back to that post-training results to see how much of a difference was made in the post-intervention compared to the pre-intervention. The other thing we looked at was magnitude of behavioral change in the medical student body across those 3 team settings. So we're going to describe the graph here, and then we'll show the data. On the vertical axis, on the left side of the screen, we have magnitude of change, which is expressed as a Cohen's d effect size number. A couple of benchmarks for the effect size number are shown in the colored lines. So you can see the green line at the top indicates that Cohen's high effect line of a D 0.8. The gray line is a Cohen's moderate effect line of 0.5, and the Cohen's low effect line is in red, and that's at 0.2. These are just measures with regard to a standard of deviation. In the blue box, we have the area of training focus, and specifically where our intervention, based upon our pre-survey results, we decided to focus our attention. Along the bottom are a couple of competency, or a couple of domains that we tested. So first, we looked at perceived preparedness for team events and the student body. We looked at frequency of briefing and debriefing as its own category, and then we looked at all the TeamSTEPPS competencies, or the TeamSTEPPS module competencies, the module leadership behaviors, team setup and structure, communication, mutual support, situation monitoring, and teamwork attitudes. As you can see on the right side of the screen, mutual support and situation monitoring, while they were included within our didactic and our training as components of teamwork, they were not focus areas for our intervention or prime focus areas, as we chose to cover those in follow-on modules or a follow-on training initiative. So here's our data. A couple of key points to kind of describe. First, we only calculated Cohen's d effects for data that was statistically significant. Thus, anything plotted had results that were statistically significant. So we found statistical significance within all targeted competency domains, or behavioral competency domains, except one exception was the communication behaviors within the anatomy lab group. And the anatomy lab group is shown in blue, as you can see the key at the top of the screen. Then we did a Cohen's d to understand magnitude of change within those teamwork behaviors. So for the most part, we'll talk a second about anatomy lab, but for the most part, we had medium to high effect for perceived preparedness for team events, the first level, the first domain on the left, as well as frequency of briefing and debriefing, and then leadership behaviors nearly across all 3 groups. In the middle of the graph, in the middle of the horizontal axis, we had low to medium effect for team setup as well as communications. And we believe that these results can be explained because for team setup, in each of these student team settings, teams were actually pre-selected by faculty or the specific program. So there wasn't a lot of team flexibility or leadership flexibility to develop or modify team structure that the team leader had. In the anatomy lab, additionally, with regard to communication, there's no real way to use SBAR or handoff tools in an anatomy lab environment, and the patient, because it's a cadaver, is really not able to communicate. And we can actually see that reflected in the results because we can see not a statistically significant change in communication behaviors within the anatomy lab. For the M2 Promise Clinic groups, we can see as far as communication, a lower effect than we hopefully desired, but it's a focus point for further improvement during our next revision of trainings. The final point to kind of bring up on this slide is there's a very clear gradient that will be emphasized on this slide as well as the next slide. There is a general trend that the greatest magnitude of change in behavior was consistently within the Promise Clinic, with a couple of minor exceptions. The next greatest change was in the M2 interprofessional learner team group, and the last, or the lowest magnitude of behavioral change, was in the M1 anatomy group. This slide actually shows student perceived effectiveness of teamwork training in 3 settings. On the left, we have our our 3 individual groups, our team training settings. On the horizontal axis, we have ratio of positive to negative responses. And then in blue, we have pre-training results, and in red, we have the post-training results. What we can see is that students in the pre-training survey had a low perceived effectiveness for existing teamwork training. And what that means is that their ratio is right around 1. So that means for every student that said that the teamwork training curriculum was positive, there was another student that said it was negative, and the ratio stayed right around 1. So what we see in the post-training survey is that there's a significant improvement, the most in Promise Clinic, the second most in the M2 home visit interprofessional learner team group, and the least in the M1 anatomy lab. Kind of a couple of interesting points from this graph is that the same exact teamwork training and the same teamwork training model is not as equally impactful across all team settings, even with the same teamwork intervention and core principles. And what we found is this may actually be representative of the variability in training impact that's seen within the literature across multiple academic interventions. But this is actually this actually shows that same difference and that same variability in one student body, just multiple team environments. And we saw that the same gradient is present, with Promise Clinic being the largest change, M2 home visit, like we said, being the next largest, and then M1 anatomy lab being the least positive change. What we did was we looked at M2 home visit as well as the M1 anatomy lab, and we said, why is there such a difference? So we looked for variation across the groups, and we did a teamwork barrier analysis, specifically in M2 home visit and the M1 anatomy lab team, to understand what was going on and where the barriers were present that were limiting training effectiveness. So here are the results of our barrier analysis. On the right, we have the TeamSTEPPS evidence-based barriers to teamwork graphic. I changed the color slightly just for the slideshow to make it more clear to read, and I also regrouped things just to make them easier to show and group them into categories by what was present in the M2 home visit interprofessional learner team group and what was present within the M1 anatomy lab group, but the same things are there that is always on the TeamSTEPPS barriers slide. In the M2 home visit interprofessional learner team environments, those students expressed that there was significant inter-team training disparities. And what we found is that while there was a medical school, pharmacy school, and social work school all involved within the program, that one of the schools actually didn't free up student schedules to allow them to make the actual TeamSTEPPS training. And therefore, within one single team, certain members were trained in TeamSTEPPS and certain members weren't. Additionally, participation requirements we found were not standardized across schools. One school, the medical school, had X number of home visits required, right? The social work school had Y, and then the nursing school, the pharmacy school had Z. And so what this led was that students would do their individual schools, or they would meet their school's minimum requirements for their interprofessional learner team home visits, and then they said, okay, well, I'm complete with my school's requirements, and I'm going to stop attending team visits. That led to a complete breakdown in teamwork and a complete breakdown in communication, as those team members generally stopped replying to team emails because they thought that their requirements were complete. So you can see not only a breakdown in team structure, you can see a breakdown in communication and overall frustrations with teamwork, all based upon some institutional and programmatic imposed barriers. In the anatomy lab environment, students felt there was just too much to do with all of the competing anatomy lab objectives. So the anatomy lab environment for medical students is extremely busy, and there's a whole lot to be able to identify and a whole lot to do. And so trying to dump all of the TeamSTEPPS training and say use all of this within the anatomy lab, right, was found by students to be too much. They said, I like some of it, but we can't do all of this in the anatomy lab, so it's just adding too much to our plate. And we think a lot of that is the same as trying to add a bunch of TeamSTEPPS onto a provider's already complex workload, is if they can't do it, learn it in a more simpler fashion, if they're going to assume that it's too much and it can't compete into their already busy schedule. What we found was present in both groups, both the M2 home visit and interprofessional learner team group, as well as the anatomy lab group, is that both groups desired actually spreading this training from just that individual team setting to more small group reinforcement throughout the M1 through M4 years, or the first through fourth years of medical school. They wanted more reinforcement in a longitudinal fashion rather than just a quick shot of TeamSTEPPS. Additionally, they all mentioned that there is insufficient faculty support and knowledge of concepts to truly reinforce student development of TeamSTEPPS and teamwork training.
Great. Thanks, Rick. So from there, we'll transition right into our next section, in which we will review some of our key results that Rick presented and also tie them into the most critical lessons that we have learned along the way over these past couple of years. First, let's start with another quick look at our pre-intervention data that shows that there's a clear deficiency in briefing and debriefing in our baseline pre-intervention curriculum, which does not incorporate a structured teamwork training. That finding is what led us to our first lesson, which is that at Robert Wood Johnson, a quote-unquote exposure-based curriculum results in improper teamwork habit patterns, namely a environment in which students typically do not brief and debrief team encounters. By extension, it led us to our second lesson, which is that the medical education curriculum needs an effective teamwork training model. Basically, our baseline curriculum is not getting it done, and something else is required. For us, that was a teamwork training model for medical education, which is possibly generalizable to all of interprofessional education. Next, we're going to revisit this Cohen-C chart, which shows that our intervention did, in fact, drive behavioral change in all settings within our targeted competency domains. This, in turn, led us to our second key lesson, which is that a student-led, faculty-supported TeamSTEPPS training can be effective in a medical education curriculum. The corollary here is that all of our student champions had significant prior experience in team-based settings, as Rick and I were discussing earlier. This in turn leads us to believe that this type of initiative will likely be most effective if the student champions involved are actually able to leverage prior experiences in teamwork and culture of safety settings. For example, leadership roles within the military, commercial aviation, etc. Next, let's take another look at this data, which shows students' perceived effectiveness of teamwork training that was delivered. What's clear here is that there is a variation in perceived effectiveness across groups, and that is what led us to the barrier analysis that Rick described, which in turn set up our next two lessons. Through our open-ended responses, we found that students do in fact have a strong desire for teamwork training within curriculum. That is to say, as students, we know that teamwork skills are required and we want to be effective team members and leaders in future. However, unexpectedly, we found that the most limiting barriers to effective training were first, institutional and programmatically imposed, and second, different than those we had forecasted and attempted to account for in our implementation, planning, and research phase. In addition, our Cohen's-D analysis shows us that these barriers do in fact have a significant impact. That is, as our fourth lesson shows, the magnitude of behavioral change is inversely proportional to the presence of barriers. What we mean to say there is that the settings which had less barriers actually had a higher level of impact per the Cohen's-D analysis. Our fifth lesson is slightly more involved. We're going to swing back to this chart to set the stage. As Rick mentioned earlier, our data reveals a pretty clear performance gradient across teamwork environments. This chart shows that while our intervention was effective for improving performance in our targeted teamwork domains across the three settings, In general, the highest magnitude of change was seen in the Promise Clinic setting, which is represented here by the gray bars. In seeing this data, we wanted to go one step further and actually address the question of why this gradient exists. Now, Rick spoke about some of the barriers that were identified in the other two settings, but we wanted to talk a little bit about what made the Promise Clinic setting more likely to succeed. Understanding why requires a quick description of what the Promise Clinic is. In short, Promise Clinic is a student-run free clinic at the RWJMS, which serves the uninsured population around our medical school. Students generally are involved for a full 4-year period while they're in medical school. But the significance of the fact that it's a student-run free clinic is that beyond being a setting where a team of student doctors provides primary care, it is a true student-run clinic, which means that students are involved not just in the patient care, but also in the weekly and annual general operations and curriculum planning for the students who are involved in patient care. From our side, we were very fortunate in our implementation phase to have a few key student champions who were highly involved with the administrative side of things in Promise Clinic. This in turn allowed for much more direct barrier identification and mitigation during our implementation process versus in other settings where the barriers might be identified, but they weren't so easily addressed throughout the academic year. In sum, this resulted in a team setting at the Promise Clinic that did not have many of the barriers that were identified in other settings. At the Promise Clinic, there was clear clinical application for the TeamSTEPPS tools that we were teaching. There was training and TeamSTEPPS tool use that was reinforced via the student leadership of Promise Clinic. All Promise Clinic students received TeamSTEPPS training. That is to say that there were equal expectations and training across the students involved. And finally, there was the Promise Clinic involved student-led appointments with consistent team member attendance. We believe that the reason for this was that the reason for the lack of barriers here was our having vested master-trained students that were involved with the Promise Clinic who were able to be drivers of change within the organization. Finally, as evidenced by the increased effectiveness of our intervention in settings where we were able to actually identify and break down barriers, we come to our final lesson learned. Our experience shows that it is very likely that the process of developing a culture of teamwork will reveal programmatic and unforeseen barriers that lie latent. Therefore, our final lesson is that effective training requires recurring barrier analysis and iterative change. The 5 lessons on this slide are what we are using to drive our vision of what comes next for our own intervention within our own medical school curriculum. But we also believe that these lessons may be more broadly generalizable and can be applied in other health professional curricula as well. At this point, I'm going to hand it over to Rick to discuss how these lessons might be applied moving forward.
So that understanding of our results and lessons learned from Tom, we're going to describe how to take that information and apply it to help design an effective teamwork training within an interprofessional environment or medical school environment. Here's like our final slide, or not final slide, but our wrap-up of the calendar and the timeline that Tom initially had started to describe, with everything here on one graphic. At the bottom, what you can see in yellow is iterative change. We took information from our initial survey, fueled that into build an initial student training environment, and then used data from that in order to do iterative change and begin the development or revise the curriculum for this year's unveiling of this year's curriculum. Initially we kind of reviewed these results. These were our post-intervention results of frequency of briefing and frequency of debriefing of medical students across all 3 environments. When we first looked at this, we were encouraged because we saw a fairly significant change and almost a flip-flop of the graphic from when we started and we surveyed students in the exposure-based curriculum. But given the correlation to reduction in patient mortality and morbidity that we found that was described earlier, we said there's room for improvement, right? When we made significant changes, we still have a large portion of our student body that is not in the always category for briefing and debriefing. In fact, that percentage is 40%. And given the link between briefing and debriefing frequency and reduced mortality in our patients, we need to do better. We found that we owe it to our patients, as students trained to be physicians and healthcare providers, as the next generation of medicine, to graduate ready and able to practice amidst the demands of current day medicine and armed with the evidence-based teamwork knowledge and skills to aid in overcoming the high preventable error rates that are plaguing our healthcare industry. So we have got to keep driving forward. We have to keep identifying and overcoming barriers such that we can iteratively enhance the quality of our TeamSTEPPS curricular intervention until nearly all students are consistently and routinely briefing and debriefing, increasing the quality of providers that we can graduate into the new physician or interprofessional healthcare workforce. So where have we decided to go from here, right? We've searched through our survey responses, we've read the course critiques, we've talked to individual faculty, and we've solicited student feedback one-on-one for ways to make our intervention more effective and more conducive to student learning. Well, part of that was revising the Teamwork Playbook. And what we have is some other suggestions that we've pulled together. Our guiding principle to shape our next revision, or our guiding principle to shape the next revision of the curriculum, or that you might find helpful in your curriculum if you're a listener, anchored in the desire of students and how they would like to learn TeamSTEPPS. So we found that students have a strong desire for standardized teamwork training. In fact, their desire is strong, but their training may be limited by institutional or programmatic barriers that Tom discussed. Additionally, longitudinal TeamSTEPPS curriculum is likely more effective than a traditional single-dose curriculum, such as a 2-day Master Trainer course. While the Master Trainer course is fantastic, there aren't many curriculums within medicine that can fit a 2-day course within their actual, 2, 3, or 4-year academic curriculum. The suggested model that students seem to like is a series of 30 to 45-minute didactic lectures on core concepts, and then recurring small group case-based application throughout a longitudinal curricular thread. In addition, the organized one-page pocket reference that we had posted seemed to be helpful for students because it was a one-pager that they could pull out of their white coat pocket and organized in a fashion that would help them from start to finish through planning a teamwork event. We also found that sufficient faculty support and coaching is absolutely critical, not only for clinical reinforcement, but to keep the initiative synchronized between the medical school or the interprofessional healthcare school, as well as the clinical hospital or academic healthcare environment. We also think that tying the TeamSTEPPS and teamwork principles into the reward pathway, or tying the training into a reward pathway, for example, graded events, is important. It basically helps to enhance student motivation. I think all students in an academic healthcare environment are motivated by grades and by seeing, some type of grade performance feedback. And so by tying that into a graded event or a series of graded events, we can help to tie into student motivations. So we talked a little bit about this survey and our results with AHA, and when discussing it, they recommended that we do a quick poll of listeners to better understand the appetite for using the lessons learned that we're describing here and those of other interprofessional institutions to develop a standardized interprofessional teamwork training curriculum that AHA could potentially release to healthcare education. So I think Abby and the crew are going to put up a survey here, and we'd like you to indicate your level of interest in a standardized AHA TeamSTEPPS program for interprofessional education curriculums. So we'll give you a minute or so, or the listeners, to rank their results. We'll give it another 30 seconds or so. It looks like we have maybe 30% of people on the webinar answering. So if you guys have a chance and you see the survey in the bottom of the screen, please indicate your level of interest. Okay, so we can show, looks like that's probably where we'll, where we are. I think we can show those results if you guys, we go close it. All right, so I don't know if you guys can see the screen too. Yeah, it looks like 45% said extremely interested, and another 40% said very interested. So that's good feedback for just where the people are on the line, and we'll kind of conclude here. So in addition to our TeamSTEPPS intervention, one of the things Tom mentioned was that we were interested in inspiring cultural change. So what we found is that we started in the first and second years of medical school, and the results of our program led to expansion into the third and fourth years of medical school. And what we did was we're now moving into simulator reinforcement within the third and fourth years clinical environments of medical school. We also grew our TeamSTEPPS movement across interprofessional schools at Rutgers, and it's now a synchronized element for certain interprofessional environments between multiple of the healthcare schools. We integrated TeamSTEPPS into multiple hospital departments. A couple of the residency programs picked up TeamSTEPPS as their training program, and then we've actually been requested to brief our project results to the Robert Wood Johnson Executive Council and the Chief Medical Officer at RWJ Barnabas, which is the 11 hospital system within New Jersey. Within the TeamSTEPPS community, we attended the TeamSTEPPS National Conference and did a poster last year, and we also were asked to write up a case study as one of 3 national case studies for the American Association of Medical Colleges Accelerating Change in Medical Education Consortium, which is being reviewed by the AAMC currently.
All right, so we want to close with another student reflection. This one's slightly different than our first one, from spring 2017 after our TeamSTEPPS intervention had taken place. It reads, quote, "TeamSTEPPS has transformed how my team functions. We are so much more organized, directed, and efficient. Communication and knowledge of our roles has greatly increased. I think it has translated to better care for our patients and a better experience for students," end quote. We believe that the student-led, faculty-supported teamwork training model we developed and implemented here at Rutgers Robert Wood Johnson is just the start of what can be done within medical education and other health professional curricula, and we're excited to work with the broader TeamSTEPPS community to make this a reality. Thank you for your attention. We'll turn it over for questions.
Wow, thanks, Rick and Tom. That was great. It seems like you guys are doing a lot of good work over there. I'll jump right into questions. To start with, so Kristen said, was simulation used to reinforce practice for these concepts at all?
I'll take that. So we, in our initial initiative at the M1 and the M2 or the first couple year level, we didn't use simulation, we just used team environments, but then now we've actually expanded and we're building a simulation curriculum for the third and fourth year, the last 2 years of medical school, and we're looking to expand that this year.
Great, thanks. And then Julia asked, how did you define team events as it relates to the evaluation where you discussed whether or not students briefed or debriefed?
Good question. I can take that one. So basically, the team events were different for each of the 3 team settings. The team settings were identified as instances that existed within the medical school curricula where groups of students were put together to work towards a defined objective. So for each of the 3 team settings, the team events varied. For anatomy lab, team events were generally a dissection that a group of 5 students would be completing. For the ILT, the interprofessional learning team home visits, it was actually a visit to a patient's home whereby a team had to assess and come up with a collaborative plan. And for the Promise Clinic, they were the team events in question were appointments for the patient population that we serve that a student team comprising of 4 medical students would provide primary care at. So the events themselves varied depending on the teamwork setting that we were serving.
But to add, the teams were consistent across each of those events. So you would do the same home visit, right, multiple times, see the same patient multiple times with the same team, or you would do an anatomy lab dissection multiple times with the same team. So you knew the same 4 or 5 member student team that you were operating on.
Great. Another question is about your playbook. Did you use the playbook with the pocket guide, or was it used as an alternative? How did you kind of come to using it?
So we, all we did was basically use the pocket guide as our baseline to develop the playbook. But then when we distroed the information to students, we just distroed it in the playbook format because it was effectively a consolidated, pocket guide with some modification like we showed of brief and debrief and team structure tools to med student environments.
And in each of the 90-minute didactic sessions, we would walk through the playbook so that students knew exactly where the pre-event tools were, where the post-event tools were, and where they could find the other tools that they could use. So across all team settings, students were familiar with the same reference guide, so that it was kind of our universal foundational reference.
Great. So another question we have, just kind of as a follow-up from Julia is, did the teams in the clinic include other persons than the medical students? Did they include the nurses or MAs, for instance?
So again, depends on the environment that we were describing. In the M2 interprofessional learning team environment, the team was comprised of a medical student, a pharmacy student, and a social work student, all from the Rutgers community. So that was an interprofessional team. In the clinic, at the Promise Clinic, the team's comprised of 4 medical students, but depending on the patient's healthcare needs, we also have PharmD students that consult. We have a medical social work student that consults as well. So those were interprofessional environments as well, with the core team being comprised of medical students.
Great. So Kristen asked, what are your thoughts on integrating TeamSTEPPS trained students and providers into healthcare environments wherein the majority of professionals are not TeamSTEPPS trained? Will those who are TeamSTEPPS trained continue to use behaviors, or will they find obstacles and challenges, especially with hierarchy?
That is such a good question. Yeah, thanks for bringing that up. I forget if that was Kristen. So you're absolutely right. What we've found is that I think the biggest challenge, and this is found in the literature, is that the largest challenge are sometimes faculty attitudes. And it's not intentional, but if faculty have spent their training and their careers not training in TeamSTEPPS and they develop habit patterns, they operate a certain way. And then if you train students, then the clinical reinforcement from the faculty side may not be there. And so we did a couple of things. First, we agree that if it's just a student teaching student environment, then it's going to be challenged to help reinforce those skills when they hit the hospital environment. What we told our students to do is we taught them how to pull information. For example, hey, if your faculty or if your leader isn't using the team brief checklist, you can still ask and say, hey, what is my role or responsibility for the team? What are the other members' roles and responsibilities for the team? What's our plan of care? What's our contingency plan? So the team itself can actually pull information such that information is shared, and we can develop a shared mental model from the bottom up, actually. Additionally, what we did was our initiative, since it grew a lot of positive results, we were fortunate to connect with some key faculty champions who, like Tom mentioned, we brought in Kevin and Rita to do a TeamSTEPPS master training course to train clinical faculty. So we began to hit it from both sides, the students kind of pushing up and then the faculty kind of pushing from the top, such that we could hopefully neutralize the training gradient within students and faculty.
And then just to chime in on that too, Kristen, that's a question that I think about often from the standpoint both of a student but also as a former educator. And I think that the thing that I kind of come back to always is that it's true that the fact that students being trained with these teamwork tools may not be in an environment the next day or the next month or the next year where they can actually practice it, right? If the hospital faculty or staff or attendings are not supporting the use of those tools. That being said, our goal in providing this training is more than just immediate. We're kind of thinking about this from the long-term grassroots standpoint, where we actually want the next generation of medical students and healthcare professionals to be speaking this common language so that when they get out into their professional careers, they are equipped to be able to implement these tools in a successful and sustainable way.
Great. Well, we're at the top of the hour, so I am going to close this webinar out now, but thank you so much to Rick and Tom and all our participants and your great questions. This was a great webinar, a lot to think about, and hopefully use moving forward. So thank you, everyone, and have a great rest of your day.
Thank you, ladies and gentlemen. This concludes today's event. You may now disconnect your lines, log off the webinar. Have a great afternoon.